This is Dr. Joshua Cooper, and this presentation is on entrainment of scar-based reentrant ventricular tachycardia. It's a complex topic that is talked about a fair amount, but I'm hopeful that this presentation will be unique because I will go through the topic in a very logical sequence and hopefully make what can be a very complicated topic much simpler to understand. When putting together this talk, I tried to think of the logical steps that I follow when thinking about entrainment of ventricular tachycardia, including some missing pieces that sometimes people, when they teach the topic, forget to address in detail. We're first going to talk about the purpose of VT entrainment. Why do we bother doing it at all? We're going to talk about the anatomy and the geometry of a VT circuit, and thereby talk about the best place it can be ablated to permanently eliminate it. We're going to review the basic concepts of entrainment and the post-pacing interval. I have a separate video on this topic, but we're going to cover the basics in this presentation as well. We're going to talk about electrogram recording from bipolar electrograms and the impact of scar on electrogram recording. We're going to talk about pacing in the myocardium and the QRS morphology that comes during pacing and how the presence of scar will impact that QRS morphology and the timing between pacing and the beginning of the QRS. We're going to talk about the interplay between pacing and recording of electrograms in and around scar, which is very important to understand during entrainment. And then we're going to put it all together and show some examples of entrainment during ventricular tachycardia from different places in and around VT circuits using the post-pacing interval, the QRS morphology during entrainment pacing, and the stim-QRS time, which together will show us where we are with respect to the circuit, and I'll show you why that's important when we talk about VT ablation. Let's start thinking about reentrant ventricular tachycardia by looking at this wonderful video that was posted to social media by Dr. El Hamriti, who I asked for permission to use in this educational video. This shows the left ventricle with extensive myocardial scar. This is a voltage map with respect to the color, and red shows very low voltage and purple shows normal voltage, and you can see there's a large area of scar, especially here on the anteroapical portion of the left ventricle. And then you can see also a ventricular tachycardia circuit being shown as a wavefront that is propagating through this area of scar. There are so many things that we can learn just from this video. First of all, we can see that a voltage map alone doesn't really show us nearly the detail we need to understand how ventricular tachycardia propagates through areas of myocardial scar. The voltage map alone doesn't show us where barriers may be. It doesn't show us conduction velocity. For example, we can see there's slow conduction going through this area of red, but faster conduction going through this area of red. And so the VT circuit is far more complex than a voltage map alone. When we start a VT case for ablation, the first thing that we typically do is to create the anatomy and the geometry of the chamber where we're working, usually the left ventricle, and that includes making a voltage map during sinus rhythm or during ventricular pacing. Here's an example of a patient with ventricular tachycardia with a smaller area of scar compared to the previous example. And sometimes it's tempting to simply say, look, let's not induce ventricular tachycardia. That can be complex and drop the blood pressure. Let's just use this voltage map and ablate in the scar and try to get rid of the VT while ablating in sinus rhythm or ventricular pacing. So for example, one might place some lesions here, but if one did so in this particular case, those lesions would not terminate the clinical ventricular tachycardia, nor would ablation lesions here, nor here, nor here, even though these are all in and around the area of scar. If you placed ablation lesions here, however, that would terminate the VT. So why is that place so special? Here is an activation map of the same patient showing ventricular tachycardia, and now we see a color scheme and wavefront propagation going in and around the scar, showing us where this VT circuit actually lies. And if we then look at these same lesions I drew on the left, looking at the activation map instead, we can easily understand that ablation in this location will tie together two electrical barriers. It spans a critical isthmus, a critical portion of the VT circuit, thereby cutting it off and preventing it from propagating. Whereas all of the other lesions that I had shown, while in areas of low voltage and scar, are insufficient to cut off the VT circuit, which could travel around those lesions, and the VT would continue. Well, you could say, it's not that big a scar, let's just simply ablate everywhere and do substrate modification. And that's not an unreasonable approach if the scar area is very small. However, if you don't know where the VT circuit or a critical isthmus of the circuit, and we'll define that term soon, are located, then it's possible that you may actually not have lesions that span one barrier to the other, and you still could have, even with all of these lesions, a VT circuit that could meander in and around the scar. You might not have lesions that are next to each other in the critical location where the VT would be terminated. In addition, if you have an area of massive scar or multiple areas of scar, it can be quite a daunting prospect to try to ablate every single area of low voltage and slow conduction and scar and simply rely on substrate modification alone to eliminate the one or more clinical VTs. So this approach is, while in one way is a brute force method of tackling VT, is not so elegant and in fact may not be successful, especially if the patient has a VT that's slow enough to be tolerated and mapped. Let's start by talking about myocardial scar and the anatomy and geometry of a reentry VT circuit. Here are two electrical barriers, and the zone between them is an area of slow conduction. The myocardium that is embedded within a region of scar typically is diseased. There are small channels with twists and turns that slows wavefront propagation, and so I drew this zone within the scar as a darker red, signifying it's a zone of slow conduction. Here is what a VT circuit might look like, where you have slow conduction traveling through and within myocardial scar, coming back out to normal myocardium, traveling through more normal myocardium around the periphery of the scar, and then entering back into a zone of slow conduction, meandering through the scar again. The QRS morphology during VT of this type will be determined by where the wavefront exits the area of scar out to more normal myocardium, where it breaks out into faster conduction, traveling across the left and right ventricles and creating the QRS, or what we would call electrical systole. The VT again would be determined by this one site, which, as we'll review shortly, is called an exit site. There are other channels and areas of slow conduction all throughout the scar that are not participating in a VT circuit. And while VT is occurring, you're getting, shown here in white, these wavefronts that are propagating through all these little twists and turns and other channels throughout the scar as well. And of course, ablation at those sites will not affect the VT, but you need to ablate the VT in a critical area shown with yellow arrows that is essential to the propagation of that particular VT circuit. Let's talk about the names. As much as I hate using nomenclature right away in a presentation, it's important for a discussion about VT that we all use the same terms and that you know what these terms are when somebody is talking about VT ablation. We talked about this breakout site where a slow propagating wavefront exits the scar out to normal myocardium and from where the QRS initiates. The morphology of the QRS is determined by this site, which is known as the exit. Here, where the wavefront turns around through more normal myocardium and goes back into the scar, this site is known as the entrance. And this slowly conducting critical portion of the circuit within the scar is known as the isthmus, here shown in C. There are different components of the isthmus depending on how close to the exit or entrance you are, so people may talk about the central isthmus or the distal isthmus or the proximal isthmus, but this is all known as the isthmus of the VT circuit within the scar. The propagating wavefront that circumnavigates around the edge of the scar is known as the outer loop of the VT circuit. You can have channels that may be electrically connected to the isthmus but are blind ends traveling in scar but are non-essential components to the VT circuit, and this is called an internal or an adjacent bystander. You can have more complex communications with the circuit, for example, connecting at two different ends. This is known as an inner loop, and we'll review at the end of this presentation different types of inner loops. There can be dominant or active inner loops that actually are responsible and participate in the active VT. You can have non-dominant or passive inner loops where this is slower conduction than the VT circuit itself, and ablation therefore would not necessarily affect the VT, and we'll review that at the end. All the rest of the myocardium that is not in or around the scar or the VT circuit is known as a remote bystander. That can be in normal myocardium, as shown here, where G is located. But you can also have remote bystander sites that are in the same or other areas of scar that have no electrical communication whatsoever to the VT circuit, but pacing and recording at those sites will have slightly different properties than other sites that are labeled here. It is important to recognize all these different components because as we go through ventricular tachycardia entrainment, the pacing and recording of electrograms at these sites will all look different, and we will be able to distinguish every single different type of location by doing entrainment pacing. Why does this matter? It matters because if we're looking to ablate ventricular tachycardia, only certain locations will be effective to terminate a VT circuit. Here is one of the seminal papers from Bill Stevenson back in 1997, where they reviewed all of the different potential sites in and around VT circuits and the anatomy of those VT circuits, and they looked at the effectiveness of ablation during ventricular tachycardia. And of course, they found that it was the isthmus, the exit, the central and proximal components of the isthmus that were by far the most likely sites where ablation would be successful to terminate and eliminate VT. So how can entrainment pacing help? If we entrain during VT, we can reveal the relationship of that particular pacing site to the VT circuit using three observations that we will review. Number one, the morphology of the QRS during entrainment pacing. Number two, the post-pacing interval. And number three, the timing from the pacing stimulus to the beginning of the QRS. How do these three characteristics during entrainment help define what site is what? Here is an algorithm from that same 1997 Stevenson paper that reviews exactly that. Here we look at the QRS morphology during entrainment pacing. And when we talk about concealed fusion, that means that the shape of the QRS during entrainment pacing is exactly the same as the VT morphology. Whereas if we talk about manifest fusion or simply QRS fusion, that means that the pacing QRS morphology looks different from the VT morphology, either subtly or not so subtly. The next step in this algorithm looks at the post-pacing interval, that timing between the last pacing spike and the first recorded electrogram in that same bipole. And we talk about whether the post-pacing interval is the same as the ventricular tachycardia cycle length or not, yes or no. And that'll tell us, of course, whether we're in the circuit or not, as we'll review. And then if those two things are true, meaning your post-pacing interval was the same as the ventricular tachycardia cycle length, and your entrainment showed concealed fusion, the same shape as the VT, you then can figure out where you are in that critical isthmus by looking at the timing from the pacing stimulus to the QRS, whether that's short or medium or long or really long. And by looking at these three characteristics, you can determine all of the possible relationships with the VT circuit, from isthmus to bystander to outer loop to remote bystander. And we're going to go through all of this in this presentation. It can be very tempting when you have a patient in the lab who is in ventricular tachycardia and you start making a map to get very excited about a particular site and potentially want to skip the steps of entrainment. So for example, if one is putting a catheter here at this location and you were to see these fractionated low amplitude electrograms that are falling between the QRS complexes, you get very excited and you say, aha, maybe I'm in a place that's good for ablation. And moreover, if you were to pace from this site and you were to see that you can reproduce the shape of the QRS during pacing as the VT itself, and in addition to that, you can see there's a delay between your pacing site and the start of the QRS, you might say, why even bother doing entrainment? I have all of the features that I need. I have fractionation, I have morphology consistent. But let me show you why you need to go through all of the steps of entrainment, because this site here is not going to be effective in this VT in this particular patient. Here is that VT circuit again. And again, these are not, by the way, the VT recordings from this case. I'm superimposing hypothetical VTs on this substrate from this video. But if you look at the barriers that I drew in here, showing where the wavefront is propagating around in a figure of 8 pattern, one way versus the other way, and look at this particular site where we are recording diastolic electrograms and pacing with a long stim to QRS and replicating the VT morphology, you'll find that at this location, you're actually in a blind end. Notice the wavefront is coming through a critical isthmus and exiting here, but also notice that there is a little channel going backwards into where this recording site is located. Ablation here is not going to affect the VT. You're not in a critical isthmus, but you're going to see these tempting features during recording and pacing. And if you then went through all of the steps, you would find that the post-pacing interval at this location is long, significantly longer than the VT cycle length, signifying that you are not in the circuit and that ablation at this location will not be effective. Okay, let's go through all the steps then so we can learn how entrainment can be helpful to guide ablation. We're going to start actually with the post-pacing interval because it's such a critical concept to understand whether you are pacing at a site that is in a circuit or away from a circuit. And I review the post-pacing interval in great detail in this other video on entrainment and the post-pacing interval, so I would refer you to that video to go through this concept in great detail, where we'll talk about reentry, we'll talk about the excitable gap, and go through it step by step. But let's talk about just the basic concepts because it's so critical to understanding VT entrainment. So here is a simple circular drawing of a potential circuit. And let's say that the conduction speed around this circuit is 300 milliseconds. That would be the cycle length of this tachycardia. And if we put a recording bipole in myocardium in the circuit, and you have the circuit going, you have reentry going, then you're going to be recording electrograms at that site that will be spaced according to that cycle length. So the distance between these electrograms will be 300 milliseconds. That alone, as you'll see, doesn't tell you whether you're in a circuit or not, because you could go to a different place in the circuit and also have 300 millisecond electrograms, or you could go to a site away from the circuit, because if you're away from the circuit, then the moment the wavefront passes near to where your bipole is located, it'll send a wavefront away from the circuit toward your recording site. And that will happen over and over again at the cycle length of the tachycardia. So again, of course, even though you're recording in a site away from the circuit, your electrogram spacing will continue to be 300 milliseconds. So of course, recording electrograms alone will not tell you whether you are in a circuit or away from it. You can pace in a circuit to take it over. Sometimes it takes several pacing pulses faster than the tachycardia to capture tissue that is excitable rather than refractory. So here's an example of that same circuit, which would go around at 300 milliseconds. We're going to pace in the circuit at 280 milliseconds. And each time we do so, we basically are jumping forward or leapfrogging forward within the circuit. We're not waiting for the circuit, the wavefront to come all the way around back to my pacing site, but instead the wavefront will travel around. It would have taken 300 milliseconds to get back to my site, but we're going to pace a little faster and capture tissue, and that basically skips this last 20 milliseconds and sends a new wavefront traveling forward each time we pace. This concept of pacing over and over again, capturing the myocardium and sending a new wavefront around the same circuit is known, of course, as entrainment or continuous resetting. This same concept can happen if you pace away from a circuit. So the mere fact that you can advance and accelerate a tachycardia from a pacing site also alone does not tell you that you're in a circuit or away from a circuit, because you could do the same thing. It might take a few more beats for your pacing site to send wavefronts to the circuit and capture excitable tissue. But if you pace over and over again, you again, even away from the circuit, can entrain or advance the tachycardia repeatedly if you continue to pace, again at a rate that's a little faster, a little shorter cycle length than the tachycardia itself. However, if you combine these two concepts, recording of electrograms and pacing a little faster than the tachycardia to entrain or continuously reset, then you get critical information about the post-pacing interval when you stop pacing, and let's see why that is helpful. If you are pacing and recording from a site within a VT circuit, then while you're pacing faster than the tachycardia, let's say again at 280 milliseconds, you're going to see pacing artifacts that of course is going to be spaced according to your pacing rate or cycle length. But then when you come off pacing, that last paced beat is going to send a wavefront around the circuit like this, and you're now waiting for it to reach your bipole because you've stopped pacing. And if you're in the circuit, the time it takes between that last paced beat to the first electrogram in that same bipole will be the same as the tachycardia cycle length. This post-pacing interval will be identical to the tachycardia cycle length, and that tells you that you must have been pacing within the circuit. In contrast, if you are entraining and recording from away from the circuit, then you're going to again see pacing artifacts at the rate of pacing. Here we are at 280 milliseconds, and now we're going to stop pacing. At that last paced pulse is going to send a wavefront to the circuit, around the circuit, and then back to your recording site. And now the post-pacing interval is going to be longer than the tachycardia cycle length because it includes the time it took to get to the circuit, around the circuit, and back. Now I have drawn this as if the entrance and the exit are next to each other, but the same principle applies. If I had to go to the circuit in this location, it went around the circuit and it exited in a different location, there still is the extra time that it takes to get to and from the circuit. So your post-pacing interval in this case is going to be longer than the tachycardia cycle length. But once the tachycardia continues after you stopped pacing, then of course the spacing between your electrograms is going to be identical to the tachycardia. So it's just this one single interval between the last paced beat and the first recording electrogram in that same bipole. Again, post-pacing interval longer than tachycardia cycle length means you're not in the circuit. All right, let's move on to electrogram recordings in myocardial scar. I review a lot about electrogram recordings in this video, the Introduction to Electrograms in the EP Lab video. So to learn more about the basics of electrogram recording, unipolar recording, bipolar recording, and lots more information, I refer you to this video. But we're going to review some of the basics and extend beyond that video to talk about myocardial scar in much more detail. We reviewed in that video when you have a wavefront that passes through normal myocardium with normal speed and you record in a bipole, you're going to get a very simple looking electrogram that reflects the wavefront passing underneath your recording bipole. We also talked in that other video about myocardial scar, and now you have all of these channels. And within your recording range, you're going to be seeing different timings and different orientations of wavefronts because of the complex environment of electrograms traveling in and around in various directions with various timings, with all of these barriers in close spacing. And you're going to see both sharp signals that are going to be close to your bipole. And again, we review this concept of near field near field electrograms, which are sharp electrograms, and then the full recording range you can see a little bit further away. That's called far field in the full recording range of that bipole. Those are more rounded or blunt electrograms, and again, those are reviewed in more detail in that other electrogram video. But here's an example of what a recording might look like in myocardial scar, where you have multiple components occupying a decent amount of time with sharper and blunter components to it. And when you think about where those recordings are coming from, think about these various channels that are located in and around the recording bipole. Here you see that the sharper types of signals are going to be and reflect transmission or propagation of wavefronts near your recording bipole, and more blunt electrograms that are recorded are going to be more rounded or far field. And here are two examples so that you can see that I'm not just drawing cartoons, but these are in fact reflective of actual types of signals that you can see in myocardial scar. Here's one example of ventricular tachycardia, where we can see electrograms being recorded from an ablation catheter, a bipole sitting within myocardium during ventricular tachycardia, and you can see this repeating pattern of near field sharp and far field blunt electrograms throughout each beat. Here's yet another example, again showing this recurring pattern of near and far field signals spanning a lot of time because of slow conduction in different channels of different timings in different directions, recorded from the same bipole, again in this case during ventricular tachycardia. I love this example in particular because it shows the electrograms that are recorded from a bipole in myocardial scar during both VT and during ventricular pacing from exactly the same site. And we can compare and contrast these fractionated, these small amplitude electrograms during VT and during pacing. During VT, we can see the signals are occurring between the QRS complexes. These are known as diastolic potentials because they are occurring during electrical diastole on the surface EKG. This reflects signals that are traveling through the myocardium, again, in between the QRS complexes, remembering, of course, that the QRS is starting where the VT exits the myocardium and travels through the large mass of normal myocardium around the scar. But once the VT goes back and re-enters the scar, you're going to see, when at least you're recording inside the heart from small bipoles, these electrical signals. But the myocardial mass in these little channels is so small that it is not reflected on the surface EKG. So we can see them inside the heart, but not on the EKG. And again, because of the slow conduction in between QRS complexes, they will occur frequently in electrical diastole. There may be other signals that are occurring during the QRS in other places still during systole, but the most interesting signals are during diastole because potentially that will include the critical isthmus that is occurring in between the beginning of the QRS and the end of the QRS. The same signals during pacing or during normal QRS conduction during sinus rhythm can be seen in a delayed fashion there as well. These during pacing or sinus rhythm are known as late potentials. These are signals that occur after the end of the QRS, and again, they reflect late activation of small areas of myocardium in the myocardial scar that are too small to be a component of the QRS itself, but can be recorded inside the heart from a bipole sitting in scar. The QRS during pacing or sinus rhythm, again, is going to be comprised of all the normal myocardium all around the scar, but if you record signals inside the scar, some of them are going to be very late, including potentially a critical isthmus from the VT circuit once it gets going, but also including other channels and components that may not be participating in a VT circuit, and these latest ones, again, are known as late potentials. These signals are very interesting, and this was recognized very early that these recordings within myocardial scar may be important with respect to ventricular tachycardia. Here's a publication back from 1988 by Sonny Jackman and his group, where they used diastolic potentials during VT as a guide for VT ablation. And they talked about the distance between the beginning of the QRS and the electrograms during electrical diastole, and found these and used these as targets for ablation. And just to give you the perspective of how insightful they were at the time with the limited tools that they had, this paper described ablation, not radiofrequency ablation, but direct current ablation. These signals were recorded at a time we didn't even yet have RF ablation. This was when they would hook up a catheter to an external defibrillator and do barotrauma, give high energy delivery of energy to myocardium to perform ablation, again, direct current ablation at the time. But they would guide those carefully placed lesions. They had to be thoughtful because these were large areas of destruction when they did DC ablation, and they were guided by diastolic potentials and did achieve some success at eliminating ventricular tachycardia simply using diastolic potentials. Here's another early paper by Dr. Almendral and group published in 2003, where they similarly used late potentials during pacing in this case, and during sinus rhythm as well. And they recognized that these late potentials meant that you had slow conduction that potentially involved critical components that were necessary for VT, and they had some success at VT ablation targeting late potentials and not using, at that time, entrainment. These were important insights as they were thinking about the substrate for VT, where circuits may be located, and using clues from electrograms that were being recorded to help guide ablation. More recently, Dr. Tung et al. Looked at these late potentials and sought to characterize them in a different way because, as I said before, there are late potentials in a critical isthmus, but there are also late potentials associated with bystanders and inner loops that are not necessary components to clinical VTs. And so they have looked at these signals in a much more robust and detailed way with more modern activation mapping techniques, and they looked at where these potentials were located with respect to the QRS, and not only the timing, but also these isochrones. They found that if you targeted the very latest late potentials, that often was not successful at eliminating clinical VT, but instead they looked at how closely spaced the isochrones were. They found where was their crowding, where were these late potentials showing their slowest propagation, their slowest conduction, and that was more successful at those sites in terms of eliminating VT, with the correlation being that if you had slow conduction, that more likely represented a critical isthmus that was necessary for VT to sustain. In any case, the point being that substrate modification can be done using diastolic potentials and late potentials, and we're learning more and more about how to characterize those late potentials and figure out which are really the ones that are essential to clinical VT. But if we go back to this example, I want to make one other point with respect to the comparison of electrograms during VT and during ventricular pacing. I've shown in red rectangles the same bipole, in this case in the proximal electrodes of the ablation catheter, and I wanted to compare these two because they show the same tissue, but interestingly, these two main signals have different timing, different distances between them during VT versus during pacing, and I wanted to explore why that's the case. Here we have the same circuit shown during VT and during pacing, and let's think about a recording bipole in these two circumstances in the same location. So, for example, if we had a recording bipole here and the green oval is showing the field of view of that bipole, and let's say this electrogram here was recorded from site 1 and this second electrogram was recorded from site 2 during VT. This is what that might look like, where you have a wavefront coming into the entrance of the scar, traveling through, let's say, a critical isthmus and hitting site 1 first, that's reflected here, and then coming around the bend into, let's say, an adjacent bystander and hitting site 2 second after a little delay. If we think about that same recording bipole during pacing, we might have been pacing from a location that sends a wavefront in the opposite direction into the scar. So for example, where we were exiting in this location during VT, we might enter the scar during pacing, in which case now these two locations are being activated more at the same time, more in parallel rather than in series. So recording at the same site, these two locations might be closer spaced. Another potential explanation on why you might see two signals closer together during pacing than during VT is reflected in this hypothetical scenario. Let's say you have a recording bipole that shows signals from these two sites. So let's say you have site 1 and 2 here, and let's say we have, in this case, pacing that enters the scar from this location, which will end up being the same location as the entrance. Now we're going to compare entering the scar from the same side, but on two different circumstances. So here we may have a wavefront traveling through the isthmus and through this, let's say, inner loop, and let's say it gets through the inner loop a little bit faster than the isthmus, but they're going to be roughly at the same time, maybe with a very slight time delay during pacing. I chose 950 milliseconds because that happens to be the coupling interval in the previous image. So let's say now we have VT that's entering in exactly the same location, that entrance site on that end of the scar. But now we are actually going into the scar at a faster rate. And again, on that previous image, the VT that I showed was at 480 millisecond cycle length. So now we're entering the same place, but at a faster rate. And you can see how I've drawn a more squiggly line through the isthmus. You can get decrement. You can get slower conduction in this critical isthmus as you bombard it at a faster rate at a shorter cycle length during VT than during pacing. And that can delay the signal in this component of the scar. So now, even though you're entering at the same site as you were during pacing, now during VT, you can have delay in that second electrogram here, and that can push it forward. And this is due to decremental conduction properties in this component of the myocardial scar as perhaps compared to this location. Another very important principle when we're thinking about the substrate of ventricular tachycardia. And in fact, that has led to another approach of substrate-based VT ablation using this concept of decremental conduction that is often necessary for a VT circuit to sustain. If you can identify areas of myocardium within scar that show decrement, then perhaps that tissue is critical to a VT circuit, because slow conduction, including decremental conduction, would be supportive of a reentry circuit being able to sustain. So this group in 2018 talked about this deep mapping or decrement evoked potential mapping, where they did S1, S2 pacing, and they looked at areas within the scar that showed late potentials or fractionated potentials that were pushed out later during shorter coupling intervals, signifying that there was decrement in that tissue as another potential way to identify critical substrate for VT without actually having to put the patient in VT. Again, just another substrate principle that is helping us do VT ablation using techniques other than entrainment mapping. Let's shift gears and talk about the QRS morphology during pacing in and around scar. I have another video that talks about pace mapping. This concept is very important, especially when you're talking about non-scar VT, focal VT, or PVC ablation. Pace mapping is very important to be able to figure out and identify a particular location and the morphology that that PVC site or that pacing site has on the surface QRS. So for more details about pacing and pace mapping, please refer to this video. But we're going to talk about some of those components and again extend it beyond into the VT ablation scenario. So in that video, I talk about a pacing site or a PVC site as well at one location that gives a particular QRS morphology, And in normal myocardium, if you go to another site, you're going to get a different QRS morphology, and a third site, you're going to get yet a different QRS morphology. And in fact, we're really good at predicting, especially in normal myocardium, where a PVC is coming from, where a pacing site is located, by simply looking at the QRS morphology on the 12-lead EKG. And I love this particular summary. This is actually a beautiful figure from this 2019 summary of looking at QRS morphology as it correlates, in this case, with outflow tract PVC or VT. Localization from the right ventricular and left ventricular outflow tract. We've gotten really good at predicting the site, for example, of a PVC from looking at the surface QRS in normal myocardium. When we get into scar barriers, however, that changes the rules, and let's see how. Again, if you have a PVC or a pacing site from this location in normal myocardium, it'll make a QRS of a particular shape. However, if you throw a scar barrier into the mix and you pace from that normal myocardial site, now your wavefronts are going to have to travel around that barrier, and that will make what had previously been straight lines of propagation into propagation wavefronts that change the vector during the QRS, and that can result in fractionation or jaggedness of the upstroke or the downstroke of the QRS. And we know this. There are people who have described this as a way on the surface EKG during sinus rhythm, during VT, to show that there is myocardial scar present. Cabrera showed this with a left bundle branch block, and Mark Josephson showed this with ventricular pacing. Here's an article from 1986 published by Kindwall and Josephson, and part of the figure from there showing this sort of fractionation or jaggedness of the QRS. And that again signifies myocardial scar with the wavefront traveling toward and away and toward again particular leads, creating that jagged appearance. What if you pace right near the scar or even within the scar? What is that going to do in terms of the QRS morphology? Well, if you paced, for example, right next to the scar here, you would get one type of QRS morphology, again, potentially with fractionation of the QRS or jaggedness because it's traveling around the scar. And if you paced at this site on the opposite side of the scar, of course, you'd get a different QRS morphology on surface EKG. And think about for a moment what happens to the myocardium within the scar as you pace and you travel within it. As I told you before, the amount of mass of that myocardium within the scar is so small that it's not going to contribute to the surface QRS. If you have a lot of it, for example, in somebody with right ventricular cardiomyopathy, a large area of scar that that has enough mass of that late activation, you actually can see an epsilon wave, a little squiggle at the end of the QRS. But in most cases, the activation of myocardium within scar, these are such small slips of muscles, it's going to be after the QRS and would only be detected when you have a bipole inside the chamber itself, and then you would see these late potentials that we have already discussed. What if you pace, though, within the scar? What shape of QRS are you going to create compared to the ones that I showed you where you're pacing outside of the scar? Well, it depends on how that wavefront propagates and where it breaks out, where the exit site or sites may be. You could, during sinus rhythm, exit out more than one location of the scar, and then you would have a resulting QRS that would be a blend, as if you were pacing from both sides of the scar at the same time. You essentially get QRS fusion because you're not going to create a QRS that's directly from that original green pacing site here, but only where you break out to normal myocardium that is of sufficient mass to start contributing and creating a QRS. So you'd have a third morphology different from either of those two if you're pacing from the halfway point right in the middle of the scar. Another interesting point to think about is the timing between the pacing stimulus and the start of the QRS. At the yellow and blue sites where you're in normal myocardium, that pacing stimulus is going to be right at the beginning of the QRS. However, If you pace inside the scar, there's going to be a delay between that pacing stimulus and the start of the QRS, because again, you're not going to see the QRS being reflected in the activation of these channels, but only once it breaks out at these exit sites. Now, what if you move around within the scar? How will that impact the QRS morphology if you're pacing during sinus rhythm? So again, we talked about this central location, and I'm now going to show regions of blue and yellow to signify the type of QRS fusion that you get pacing from different sites. What if you moved from that central site out into this blind end, which during VT might be this adjacent bystander type of site, but we're not in VT at the moment? You actually might get the exact same QRS that you just got, because you're going to potentially travel to that midpoint in that scar and then out both exit sites as before. But one interesting difference, even if the QRS shape is the same, might be the timing between the pacing stimulus and the start of the QRS. You're further away from those exit sites. So in fact, that pacing stimulus might move further away from the beginning of the QRS. The stim to QRS timing would be longer if you are further embedded, further deeper in the scar away from the exit site or sites. What if you moved from that central point over here toward one of the two exit sites? Well, then the conduction time to that closer exit site is going to be shorter than the conduction time to the opposite one. You're now going to get a different degree of fusion because you're going to give a head start to this yellow location compared to the blue. And in fact, you might actually completely swamp out the effect of exit on the opposite side of the scar and only exit out this one direction. But the point being that simply moving from the center of the scar toward the periphery of scar is going to change potentially the QRS morphology. And it also will change the stim to QRS timing, because the closer you get to the exit site, you're going to get a shorter distance between the pacing stimulus and the start of the QRS compared to when you were deeper in the scar where you had a longer stim to QRS timing. Conversely, if you moved toward the opposite exit site, you're going to get fusion favoring the opposite exit and the opposite QRS morphology. And again, you might either have a blend with different weights compared to how long it took to get to this closer exit site versus this further one, or in fact, you may completely dominate and have a morphology that is identical to the blue site, depending on how long it took and whether you had enough quick enough conduction to this exit to contribute in any meaningful way to the surface QRS. Let's think about pacing from the center of the scar during VT compared to during sinus rhythm. This is a very important concept of entrainment and QRS morphology. Here we have that VT circuit that we've talked about going through the scar and around the outer loop, and we've talked about the exit site and the entrance site during VT and how the shape of the VT is going to reflect only the exit site, right? Because here during VT, we're going to generate the QRS only from this one location because we have unidirectional wavefront propagation through the scar to the exit, and in fact this end is the entrance, so you're not going to generate a QRS from here during VT. If you were to pace from the same site where the exit is, you're going to get the same QRS morphology as the VT was creating, obviously slower, assuming you're pacing at a slower rate, or of course you could pace at the same rate as the VT and then you would replicate the VT morphology both in terms of shape and cycle length. What if you entrained, meaning you started pacing from inside the scar during VT? So now you have VT traveling around, and now you start pacing. We talked about this when I drew that circle before, when we talked about entrainment in the post-pacing interval. But now here we are with this myocardial scar. And interestingly, if you entrainment pace now, We talked before that you would have gotten a fused QRS exiting out both one way and the other way from the scar, but during VT, especially if you pace only barely faster than the VT, while you're in training, you're going to exit only out the same exit that the VT was exiting. And instead of having a fused QRS, you're going to have a QRS that reflects only exit out this one same exit site that the VT was exiting. And that, of course, will also match what the paced morphology would look like if you were pacing just from outside the scar on that end. So again, to emphasize this, because this is really important as a concept for entrainment, you can pace in scar during sinus rhythm and entrainment pacing during VT from the same site and get two different morphologies that don't look like each other. And the reason is that during sinus rhythm, you can escape out more than one way. And during VT, you can only escape out a single way, because going back in the other direction, you're going to reach refractory tissue. The oncoming VT wavefront will have entered the scar and prevent you from exiting in that direction. So you're going to only get exit out the same way that the VT was exiting, giving you a different morphology during VT entrainment than during pacing alone. And in fact, you might have, during sinus rhythm, exited only out what ends up being the entrance during VT and have a very different morphology, even if you're in a critical isthmus that, by the way, might have been good for ablation. If you're pacing during sinus rhythm, you might have a very different morphology than the VT was giving during reentry. Another corollary to that is if you were to move that pacing site to an adjacent bystander. We talked about moving to that blind end location. What if you paced from there and did entrainment? We talked again before during sinus rhythm that you could exit out both ways from the scar and have that fused QRS. But what if you did entrainment pacing from this area that, by the way, would not be a good ablation site during VT? What would the QRS look like? Well, you'd have the same scenario potentially as you did when you paced from the isthmus itself, because again, you could reach, if you paced just barely faster than the VT, you could reach refractory tissue because that VT circuit was still coming round and entering in the entrance, and even though you're in a bystander, you might still be exiting the same way as the VT, and that will give you the same morphology, or what we would call concealed fusion, the same morphology during entrainment pacing as you had during the VT itself. The one difference, though, might be, as we talked about before, when pacing during sinus rhythm from a bystander, that stim to QRS time will get longer, because here we have a longer electrical distance between that pacing site and the exit. Here is a real-life example of a recent VT ablation that I did, where we had a patient with an inferior myocardial infarction, and the patient had recurrent VT and came to the lab for ablation. This is a really nice example of this principle of pacing from the same site during VT and during sinus rhythm and getting very different QRS morphologies. Here was the scar, and we ended up actually having a circuit that traveled through the base of the ventricle toward the septum, which is here, and then around the scar, and then back into the entrance. Here is the VT itself that was slow enough, thankfully, for us to map and do entrainment. And we paced during VT from this location. We entrained. And here we created a QRS morphology that was identical to the VT. We're going to get into this entrainment concept in a little bit. But here you can see the VT cycle length was 420 milliseconds. We paced a little faster at 400 milliseconds. And so this here is the last entrained QRS from pacing, because we sped up that VT to the pacing cycle length. And there's the stim to QRS delay, because we were pacing within scar, and it took a while between pacing and the exit site, which was on the opposite side of the scar. We created a shape of the QRS that was identical to that of the VT. This is a paced and trained beat. This is a spontaneous VT beat, and they look the same. That's pacing from this site during VT. But interestingly, when we paced from that exact same site during sinus rhythm, look at the morphology. And by the way, look at the stim to QRS timing. It couldn't be more different. Here we have in lead 1 during entrainment pacing a positive QRS, but it was negative when we paced at the same site during sinus rhythm. Look at V1. We had a left bundle branch block morphology during entrainment pacing and a right bundle branch block morphology during sinus rhythm pacing from the same site. And the reason that the stim to QRS timing is much shorter is because we just, whoop, we went right out. We were very close to the entrance. And so during sinus rhythm, we could escape out the entrance as opposed to VT, where we paced just barely faster. That tissue was refractory, and we were not able to escape out that way, but we had to escape out the same way as the VT. A very powerful example showing that pacing during VT and pacing during sinus rhythm can look very different in terms of the stim to QRS, as well as the QRS morphology itself, a very important principle. Now we're going to think about pacing and electrogram recording in SCAR as they relate to each other. When we record electrograms inside the heart from a bipole during sinus rhythm or during any arrhythmia, you're going to see electrograms that are going to reflect the cycle length of the rhythm that is occurring. And here are electrograms, I guess, from normal myocardium. And when you pace from this exact same site, from the same bipole where you recorded these electrograms, what is the actual electrogram channel going to look like during pacing? Is it going to look like this, where you're going to see pacing artifact and electrogram side by side? Is it going to look like this, where you're going to see pacing artifact and electrogram kind of embedded within the artifact? Or are you going to see this, where you're going to only see pacing artifact and no electrogram at that site? It turns out that this is what you're going to see. I mean, look back at any of your cases, any of your examples, and you'll see that this is the case. When you pace from a particular site from which you were recording, the electrograms that you were recording when you weren't pacing will disappear. And why is that? If you think again about our simple myocardial diagram and the recording range of that bipole, if you now pace from that same bipole, you're going to be capturing the myocardium within a certain radius, and that includes the very same tissue that you were recording while you were not pacing, meaning that the same myocardium that you were seeing when you were not pacing is going to be immediately captured during pacing, and it's going to show up exactly at the time of your pacing artifact. So this electrogram here will get sucked in or get swallowed up, or will occur exactly simultaneous with the beginning of your pacing spike, and it will disappear. It'll be swallowed up because, again, that same range that you were recording from is now going to be simultaneously depolarized at the time of your pacing output. What happens instead if you're recording in a more complex environment where you have, let's say, two different electrograms that are both within your recording range but happen at slightly different times because, let's say, there's a little scar barrier? What happens now if you were to pace from this same bipole? Several things can happen. In this case, you're capturing one of the two electrograms. Which one is it? Well, it's the one that disappeared. This electrogram here that looks like a sharper downstroke in this example was being captured. And this one is not being captured. How do I know? Because it's not occurring simultaneous with the pacing output. You didn't capture it but the wavefront traveled to that site over a particular time that reflects the conduction time between what you captured, the periphery of the tissue that you captured, getting to that site. Now, it depends on how it got there. That electrogram that was not captured could be early compared to your pacing artifact, or it could be late. It just depends on how you get from the captured tissue to that other area that wasn't captured. In either case, regardless of the timing, you're capturing only the sharp electrogram because it disappeared, and you're not capturing the blunt electrogram. What if the opposite were true? Now, usually, by the way, you capture sharp electrogram because it's closer to the bipole, but for the sake of argument, I distinguished two different electrograms so that I can talk about them as sharp and blunt. But let's say you see this example when you pace. Well, here we captured this first, more blunt-looking electrogram because it disappeared, and we're not capturing this one. And by the way, the shape may look a little bit different because the wavefront may get to that area of myocardium in a different direction during recording when you're not pacing versus when you are pacing. But the characteristics, the sharpness, the amplitude will probably be quite similar. So don't be thrown off if during pacing you see an electrogram that looks similar to an electrogram that you saw when you weren't pacing, but it's not exactly the same. That's okay. It's probably just you're activating that little bit of myocardium in a different vector, a different orientation. But again, here we're capturing this one and not this one. What if you capture both? Well, then they'll both disappear to inside the pacing artifact. Maybe you had to turn up the energy a little bit, and we'll talk about that in a moment. But regardless of what your energy was, if you see both electrograms disappear, then you must have been capturing both of them during pacing. Let's do some real-world examples and look at pacing and then cessation of pacing and figure out what electrogram we were capturing. Here in this example, it's pretty simple because there's really only one complex electrogram that we see when we stopped pacing. Again, here's pacing artifact, here, here, and here. We stop pacing, and here is an electrogram that we're seeing recording while we're no longer pacing. Are we capturing it? Yes, it disappeared. It's gone inside the pacing stimulus because it's at the same location where we're in contact with tissue, and it gets, quote, sucked in or brought in to the pacing artifact. What about here? It's a more complex electrogram while we're not pacing. What component of this are we capturing? Well, let's figure out what component we're not capturing. If we look during pacing, we see this sort of blunt type of electrogram that is somewhat reminiscent of this blunt electrogram. Now, it looks a little different, probably because the wavefront that reaches this area when we're not pacing is traveling into it in a different way than when we're pacing. But it looks like we're not capturing the blunt stuff, but we probably are capturing the sharp stuff because we don't see that anywhere. So in this example, this is what we're capturing. Again, the key is to identify electrograms during pacing that you can see, and if you can see it while you're pacing, it means you were not capturing it. Here's another example of yet a further complex electrogram that has multiple components. What are we capturing during pacing here? Well, if we look at this component, it looks reminiscent during pacing of this part of the complex multi-component electrogram when we're not pacing. So probably this part we are not capturing. I suspect that this is the same tissue here, but we are capturing this component because this very sharp, highly fractionated signal is not seen during pacing, so this is likely what we're capturing. Here's another example. What are we capturing here? Well, there's actually only one main signal here when we're not pacing, but interestingly, we can see that same signal while we're pacing. But moreover, if you actually look at the timing of that signal during pacing, it's changing. It's getting further and further away from our pacing artifact. And in fact, if we measure the intervals between those visible electrograms and we compare it to the cycle length of pacing, we can see that that's different. So in fact, here's an example of not capturing anything. And we know that because, first of all, the only real signal that we can see while we're not pacing is still seen while we are pacing, suggesting we're not capturing it. But also, we didn't accelerate those signals to the pacing rate like we did in the other examples above. So here's an example of lack of capture. What about here? This is going to be the same thing, just another example of a slightly more fractionated signal. Here we can see this signal both when we're not pacing as well as when we are pacing, although it's starting to get swallowed up inside the tail end of the pacing artifact here. But if you measure those signals one to the next, picking a single component of it that you can use as sort of a constant reference so that you're measuring from the same part of the signal one beat to the next, you can see that that cycle length is longer and different from the pacing cycle length. So again, here we're not capturing anything. And again, you can see, just like the example immediately above, the timing from the pacing artifact to that signal is changing. It's kind of marching out, migrating away. We're not capturing any tissue during pacing here. That's important to recognize, not only what you are capturing and what you're not capturing, but whether you're capturing myocardium at all. I alluded to the concept of higher pacing output resulting in capturing instantly more myocardium a few slides ago, but let me go over that concept in a little bit more detail because it's so important to understand pacing in SCAR. I actually am stealing a slide here from my pace mapping video where I review this concept as well, but I'm going to review it here too because it's so important. Here was a study published way back in 1991 where the authors used an epicardial array of electrodes on the outer surface of a ventricle during pacing at different amplitudes, different outputs. And there were a few interesting features that they found. One is actually the shape of the myocardium that is instantly captured during pacing. You might think that it's just a circle around the electrode, but it's not. It turns out that it's a dog bone shape, they called it, or a barbell shape. This has to do a little bit with the orientation of the myocytes. But that's a little bit beyond the scope of this presentation. I want to review more the area, the volume of myocardium that's captured at different outputs. Here is the instantly captured myocardium where they paced at 1.5 milliamps. If they turned up the energy and they paced at 3 milliamps, they would instantly capture simultaneously a larger area / volume of tissue, area on the surface, but presumably this also is deeper down as well. And if they further increased the output to 5 milliamps, it was even a larger instant area, and at 7 milliamps, an even larger area. And this is all instantly captured simultaneous with the pacing artifact itself. And then the wavefront would propagate out in all directions from the outer edge of all of this instantly captured myocardium. Again, at this lower output, you would have traveled out from the outer edge of that smaller morphology, that smaller area. So how does this relate to pacing in SCAR? We talked before about the complex electrogram that you can record from within myocardial scar, where each of those electrogram components reflects a different bit of muscle, either closer to or further from the recording bipole, in this case the distal tip of an ablation catheter. So marrying those two concepts, these recording of a complex signal and pacing output, if you were to pace from this location at low output, let's say 1 milliamp here, right in SCAR, then you're going to capture a small volume of myocardium and you would, quote, suck in, or you would draw in the electrograms simultaneous with the pacing artifact that are within the tissue that's captured. So here, this electrogram will sort of essentially disappear and migrate into the pacing artifact. What will that look like here on the surface? You're going to get this appearance. Here's the pacing artifact, and see what happens to this electrogram that was immediately adjacent to the pacing stimulus. It's gone. And you're going to see all of the other components that were not immediately captured. And of course, as you pace over and over again, just like in the previous examples, you'll see all of these electrograms appear remote or outside the pacing artifact. But what happens if you pace from the same site and you turn up the energy? Well, now you're going to capture a larger volume of myocardium and incorporate any electrograms that are in that new larger area that's being captured, in this case, this electrogram. So what is that going to look like on the recording? Now this electrogram has disappeared into the pacing artifact, and you're only going to see the more far-field electrograms that are not directly captured. What if you keep going and you increase the output further? You can, quote, suck in or incorporate another component of the electrogram as you pace at 10 milliamps. And if you really crank up as high as you possibly can with high output pacing, then you might even capture more far field signals, or you might not. It depends on how far away it is and how much you're able to pace, what your energy strength is. But you, in fact, could potentially reach a point where you see none of the multi-component electrograms if you pace at high enough amplitude that, in fact, you capture all of them simultaneously. All right, let's talk about the post-pacing interval, incorporating these concepts of pacing in SCAR, capturing electrograms, and the post-pacing interval so that we know how to make that measurement. Here's a cartoon of pacing and then stopping pacing, and we're going to talk about how to make that post-pacing interval measurement. It's easy in an area where you have simple electrograms while you're not pacing, in this first cartoon, for example. So we're pacing. Here's the last 3 beats of pacing. We stop pacing. Here are electrograms, and it's pretty obvious that this is your post-pacing interval at this site. But what if this is your situation, and when you're not pacing, you have these 2 components that we talked about earlier, and during pacing, you're not capturing them both. You still see some electrogram during pacing. How do you measure this post-pacing interval? The answer is that you must measure from the last pacing stimulus to the first sharp component of the electrogram that was captured. That's how the post-pacing interval is measured. You want to know how long it took to get from that pacing site back to the electrogram that is immediately at that same pacing site, meaning the electrogram that you had captured. In this case, it's going to be measured to this. This is what you're capturing. You are not capturing this. You therefore would not measure to this electrogram, but to the first sharp component of this one. What if the opposite were true? If you captured this more rounded looking electrogram and you're not capturing the sharp one? How do you measure this post-pacing interval? Again, it's from the last pacing stimulus to the first sharpest component of the electrogram that was captured. In this case, here. Again, you're not going to measure to the sharpest thing, but to the sharpest first component of the thing that you captured. This was not captured, therefore you don't measure to it. And what if you captured both? You measure to the first sharp component of the electrograms that you captured. In this case, you would make the measurement to here, right? You're capturing both things, so you measure to the first component of whatever you captured. In this case, it's both. Fine. You measure to the first component of what you captured. Well, let's move on now. Now it's getting exciting. Let's get into some real examples of entrainment pacing during VT, focusing on the ablation distal electrogram. Here we're pacing. We have not terminated VT, which continues after we came off pacing. How are we going to measure the post-pacing interval during this entrainment maneuver? We're going to be focusing again on the ablation distal. That's where we're pacing from. That's where the main pacing artifact is seen. What are we capturing? In this case, pretty straightforward. We're capturing this electrogram. How do we know? We're not seeing it during pacing. All right, that's what we're going to measure to. Notice, by the way, that we see a different electrogram in the proximal pair of electrodes. Those are not being captured, by the way, when we're pacing from distal. We're just immediately capturing the tissue around the distal electrode, but it is not capturing the tissue a little further away. And so we would measure, in this case, the post-pacing interval from here to here. Here's another example. We're pacing during VT. We come off pacing. How are we going to make a measurement, the post-pacing interval measurement here? Are we going to measure this? Are we going to measure to this? Well, just like the other exercises, let's figure out what we're capturing. If we look carefully, we can see that during pacing, we are not capturing this signal, and that seems to correspond shape-wise, morphology-wise, to this signal. So therefore, we would not measure to this signal after we come off pacing, but we would measure to the first sharp component of the signal that we are capturing here. All right? That's what we measure to. This is our post-pacing interval with this entrainment maneuver. Notice, by the way, you can sometimes use other clues in addition to the shape of the electrograms to figure out what you're capturing. Sometimes you can use the buddy system. So in this case, for example, notice that there is an electrogram that actually is, in this case, disappearing from the proximal pair of electrodes as well. That seems to be timed with this electrogram in the distal. It's not seen, this sharp electrogram is not seen so much here, or maybe it's close to the pacing stimulus, but maybe swallowed up maybe slightly after it. That's a clue that maybe this is what we were capturing, because they both kind of disappeared, right? In contrast, if we hadn't recognized that this shape was the same as this shape, you can also use the buddy system to see what you're not capturing, right? This signal here in the proximal seems to temporally correlate with this signal in the distal. Another clue, perhaps, that we're not capturing that signal. So again, you'd measure the post-pacing interval from the pacing stimulus to this signal here. And here is example number 3, where we're entraining again during a little faster ventricular tachycardia. How are we going to measure this post-pacing interval? Are we going to measure to here? Are we going to measure to here? Well, let's look at the electrograms that we're not capturing. We see this electrogram here, and I would say that looks like morphologically it corresponds probably to this signal here when we're not pacing. In contrast, I don't see this signal anywhere, so I suspect that this is what we're capturing, right? So here we are. Those are not being captured, so I wouldn't measure to that. But this is disappearing during pacing, so that's what we're going to measure to. We can again use the buddy system concept and say, all right, well, another confirmation that this, which we didn't think we were capturing, seems to temporally correlate with this far field signal in the proximal, and these seem to go together. So further argument that this is not what we're capturing and therefore not what we should be measuring to. But there's another little trick that we can use. Look here, for example, at the time between the pacing stimulus and the beginning of the QRS. It sometimes is difficult to see where the beginning of the QRS is because there's a T wave that blends into the next QRS. So try to find somewhere where there's sort of a little sharp beginning of the QRS. I'd say it's probably easier to figure it out here. But look at the stim to QRS time, and now compare that to the electrogram to QRS time. And when you're pacing in scar and a critical isthmus, etc., this is going to be the same timing. It's a little difficult for me to draw this as arrows, but the vertical calipers will make it even clearer on your electrogram recording system. Why is this the case? So let's say we are in, an isthmus area. So during pacing, the time it takes between the pacing signal and the beginning of the QRS is going to be the time it takes to escape out to the exit site where the green arrow here is displayed. And that timing is often the same as during VT, where you've passed the recording site and then have to further travel to get to the exit. So the stim to QRS, the stim to exit time, and the electrogram recording to QRS time may be the same. Another clue to figure out which electrogram am I capturing. Another little piece of evidence. Now, this doesn't always work if you're not in a critical isthmus, and we'll show that later. But just look at all these little pieces of evidence to try to figure out what you're capturing. And here it may be clear enough by seeing what disappears during pacing. Okay, here's example number 4 of entrainment pacing of a much slower VT here, which we've accelerated to the pacing rate. And interestingly, we have a really low amplitude signal, but you can see that during pacing, and therefore we are not capturing it. In addition to noticing that this very low amplitude long signal is not captured, you can also again use the buddy system. It seems to correlate temporally with these other electrograms in the proximal that are also visible during pacing. So probably here, this is the electrogram that we're capturing, and by the way, it's buddy. It also disappears during pacing. So we would measure, in this case, from the pacing stimulus to this first sharp electrogram would be the post-pacing interval here. Here's example number 5, another entrainment maneuver in a relatively slow VT. And we can see here the VT cycle length was 520 milliseconds. And we accelerated the pacing to the pacing rate of 500 milliseconds. And the question here is really important when you measure the post-pacing interval, because if you measured to this electrogram, you're going to get a PPI, a post-pacing interval, that's shorter than the tachycardia cycle length. If you measure to this one, you're going to get a post-pacing interval that's longer than the tachycardia cycle length. So the conclusions that you're going to end up drawing are going to be very different. So it's really, really important to figure out which electrogram to measure to with your post-pacing interval. Well, notice here that during pacing, there's this electrogram, and by the way, it's buddy, that we're not capturing, and therefore, we should not measure to this electrogram, even though it's tempting. That's the first one that we're seeing, but that's not being captured, right? You can see that it's not being captured, so don't measure to it. So instead, you're going to actually measure to this. This is the actual post-pacing interval in this example, and it's so critical to get it right. Otherwise, you're going to come to the wrong conclusion. You might think you're in the circuit when you're actually out of the circuit. Here's another example. Example 6. All right, what are we capturing? All right, let's see. What do we see during pacing? All right, well, this electrogram is visible during pacing as well as after, so probably not capturing that. But so too is this signal that we can see both during pacing as well as when we're not pacing. It doesn't leave very much, does it? Well, hold on a second. Let's look at one more thing that maybe we forgot to check first. And when we go through the entrainment examples, this is going to actually be the first thing that you have to check. Look at the pacing cycle length, in this case 340 milliseconds, and look at the QRSs during pacing to make sure that you captured at all. In this case, we didn't. This is analogous when I showed before, when we were showing just the electrograms, not the surface EKG, when we measured electrogram to electrogram and we failed to accelerate it, you didn't capture anything. That same thing can be concluded when you look at the surface EKG. That's probably the first thing you should look at when you're in training. make sure you actually captured myocardium and that you advanced the QRS complexes. And here we did not. So in fact, we're capturing nothing. That explains why we can see all of these electrograms, both when we've stopped pacing as well as during pacing, because we're capturing none of it. Another clue, even before you made these measurements, is to look at the relationship between the pacing artifact and the QRSs as well. So here, the pacing artifact is sort of in the beginning part of the QRS, but here the pacing artifact is migrating earlier, and here it's migrating earlier. There's actually a dissociation between pacing and the QRSs. So even before you measured one to the next, you can see, I must not be capturing, because they're actually not consistently related to one another. All right, so then of course you can't interpret the entrainment maneuver at all because you didn't even capture. Very, very important to recognize. I love this example that Mark Josephson showed in this paper in 1999, where he was looking to figure out how can you use a single radiofrequency ablation lesion to terminate ventricular tachycardia. And he used entrainment maneuvers to find that perfect spot. Here is one of the showcase examples from that paper that he used, and I find it really interesting because it uses all the principles that we've just discussed in terms of figuring out how to measure the post-pacing interval. And look what I'm talking about. Here is the ventricular tachycardia in this figure, in this example, 442 milliseconds. And he showed it. I find it interesting, as you'll see, that he doesn't actually show sort of calipers or measurements what he's referring to, but 442 is referring to the cycle length of the tachycardia. And then pacing is occurring at 420 milliseconds, and you can tell the pacing artifact to pacing artifact is that cycle length. And if you measure QRS to QRS, you'll see that you've accelerated, advanced the QRSs to the pacing rate, and this in fact is the last advanced QRS. The question though, here's your mapping catheter, your pacing catheter. Where are you going to measure the post-pacing interval to know if your mapping catheter, your ablation catheter, is in the circuit, right? Could be any of these things. Well, let's use the principles we just discussed, and let's look at all of these signals during pacing that you're clearly not capturing. And let's look at those when you stopped pacing. All of the things that I've squared off here are not captured. So you might say, what the heck does that leave, right? Here's that last, but you are capturing something, right? You have accelerated the QRSs to the pacing rate. So what's left? Well, if you use this trick, as they did, again, they didn't actually annotate in the figure where their measurements are, but the stim to QRS time is what I'm showing in the green arrow. From the pacing stim to the beginning of the QRS is 115 milliseconds. And they used that trick of looking at the electrogram to the QRS timing, right? The EGM to QRS. If you go backwards, it's this little guy right here that you're capturing. Right? Is it possible? Is that what they're measuring to? It turns out they are. How do I know that? Because in fact they drew in their figure this arrow, which I hid. This is what they're capturing. And they showed that this electrogram to QRS timing is 115, the same timing as the stim to QRS. And so they measured their post-pacing interval to here, to this little thing. And I think they're right, actually. You wouldn't think, unless you went through all of these activities here, all of these steps to figure out what you're not capturing, and then using this stim to QRS and EGM to QRS comparison to figure out that that's where you need to measure the post-pacing interval to. And it turns out that this is exactly, post-pacing interval, exactly the same as the tachycardia cycle length. And they said, this is the spot. This is the magic spot. And we figured it out by entrainment and the post-pacing interval and the shape of the QRS and the stim to QRS timing. And sure enough, when they came on RF in 6 seconds, they terminated the VT at that site. I love that example because it's so tricky to figure out how to measure the post-pacing interval, but we can use all the tools that we've looked at to figure it out and find that right site. Okay, it's time for the big show. We're going to get into now real examples, having gone through all of the building blocks, all of the steps you need to figure out entrainment of VT. Let's do some actual examples of VT entrainment and figure out if it's a good site to ablate or not. Here we go. Here's example number 1. Here we have VT, and some of these will look familiar because I've used them in some previous slides. We're going to go through all the steps and do the full shebang here in each of these examples. Okay, here the cycle length of VT is 575 milliseconds, and pacing was performed at 550 milliseconds, a little faster than the VT. And the first thing that you're always going to do is figure out and ensure that you indeed entrained and advanced the QRSs, and then figure out which was the last advanced QRS. So let's make those measurements. Yes, we accelerated the QRSs to our pacing rate, number 1. And number 2, we can figure out which is the last advanced QRS. So this last pacing stimulus goes to this last advanced QRS because it's at 550 milliseconds. The next interval is back at the VT cycle length. So this is the one that's advanced. Here is the post-pacing interval. How do I know? It's because I'm not going to measure to the electrograms that were not captured, right? So let's go through our checklist. We talked at the beginning about the 3 components of entrainment that we're going to interpret to figure out where in the VT circuit, where in the anatomy we are located at this pacing site. So this is going to be the same thing we're going to run through this checklist every single case. So the post-pacing interval here is the same as the tachycardia cycle length, right? Pacing stimulus to the first sharp electrogram in the captured electrogram here in the distal ablation catheter. That's the same as the tachycardia cycle length. What does that mean? That means we are in the circuit, okay? The QRS morphology that's entrained is the same as the VT morphology. What does that mean? It means that we're exiting out the scar in exactly the same place as the VT is. So we're in the same region of scar during entrainment, exiting out the same way. And then the last question is, what is the stim to QRS timing? Right? Because remember, this algorithm that we talked about, where you go through and once you figure out that you have the same morphology, that's that entrainment with concealed fusion, right? And once you figured out that your post-pacing interval is the same as the VT cycle length, right? They give you a fudge factor of 30 milliseconds. That's if you have a little bit of decrement by pacing a little faster. Ideally, it'll be identical, but sometimes you do see decrement, so it may be slightly longer. Once those 2 things are true, you know that you're in a critical component of the VT circuit, but you want to know, am I closer to the exit? Am I in the middle? Am I more proximal? Am I in an inner loop? Right? Closer to the exit seems to be a little more successful than being very proximal or even in an inner loop. So this is important. So how do we do this stim to QRS over VT cycle length calculation? Let's do that. Here, the stim to QRS timing, here to here, 290 milliseconds. The VT cycle length is 575 milliseconds. That's about 50%. All right, and that puts us in the central isthmus. This is probably a really good site to ablate. It's here, and we're exiting out this way. All right, and notice also, by the way, that the stim to QRS and the electrogram to QRS are the same. That's something that you're going to see if you're in the isthmus for the reasons that we discussed before. Wonderful. Ablate away. Here's the next example. VT cycle length is 458. We're going to go through exactly the same steps, every single example, right? This looks complicated, but when you break it down, it's simple. Here's the VT cycle length. We're pacing here at 440 milliseconds, a little faster than the VT, right? And we're going to measure out and figure out, did we advance the QRSs? And if so, which is the last advanced QRS? So yes, we advanced the QRSs to the pacing cycle length, the entrainment cycle length. And this interval here is longer. So this is the last advanced QRS right here. So that means the stim to QRS time here is this, very short. And what is here the post-pacing interval? It's this. How do I know? I know because I'm looking at the things that I didn't capture during pacing, and I try to find those same things later, and I don't measure to those. This more sharp thing, I can't find that, right? What's another way? You say, oh, that's too many components. How do I know? How do I verify? Well, use, our other tricks, right? The buddy system we talked about. This is sort of disappearing. So that kind of goes with this. But also that stim to QRS, right? You say, all right, I'm going to look at this timing and say, well, let me go after I've come off pacing and go backwards. Well, it goes to here. All right, that looks valid. We've used a couple different ways, seeing what electrogram we captured and looking at the electrogram to QRS timing. So let's go through our checklist here. The post-pacing interval is the same as the tachycardia cycle length, so we're in the circuit. Great. Let's look at the morphology. Looks the same. This may be slightly different, very slightly. We'll talk about that in a second, but it's just about the same. So I'm going to call this about the same. Okay, so we're probably exiting in the same way as the VT. So we're inside the scar, just barely. And the stim to QRS is really short. And what percentage of the tachycardia cycle length is that? That's 29 milliseconds, again, from stim to the beginning of the QRS here, compared to the VT cycle length, that's 6%. And remember, that means that we're at an exit site. We're at less than 30. Right, we're close to here, so we're right there at an exit site. So why, by the way, when you're right at the exit, can you have a slightly different morphology? It depends on the pacing output, but you might be capturing not just tissue in the end of the isthmus, but you might actually be directly capturing some of the tissue that's already starting to make the QRS. You can see a little bit of fusion, a little bit of manifest fusion. It may look a little bit different when you're pacing right at the exit compared to the VT, because you're just slightly altering how you're escaping to normal myocardium, especially a little higher output if you capture some of that. So it may not be exactly the same if you're right at the exit. But this could be, maybe go back a little into the scar, but this actually is not a bad place to ablate here. Here's another example. Here's the tachycardia cycle length, same steps. Here's the pacing rate, a little faster, and let's go forward and let's see, did we advance the QRSs? Yes, we did, to 400 milliseconds, which is the last advanced QRS. It's that one. That's the last QRS that is advanced to the pacing rate. Okay. What's our post-pacing interval? It's this. How do we know? This is one of the examples we saw before. We didn't capture this stuff, right? So we're not going to measure to this stuff. It looks the same. In addition, if we do that trick, the electrogram to QRS compared to the stim to QRS, that's another confirmation way to try to figure out what you're capturing and therefore what you should measure to with your post-pacing interval. So let's go through our checklist here. Post-pacing interval is the same as the tachycardia cycle length. We're in the circuit. The QRS morphology is the same. So we're exiting out the same way as the VT does during entrainment pacing. Great. And the stim to QRS percentage of the tachycardia cycle length here is a little bit longer, 62%. So that would put us in the proximal isthmus. It's taking longer from the pacing site and from the electrogram to get out to the exit. All right. may well work. Again, it's sort of the mid-isthmus and toward the exit seems to be statistically a little bit more likely, but not a bad place necessarily. So as you entrain around, if this is the best thing you found, it may well work. It's still in the isthmus. Here's another example. Tachycardia cycle length, VT, is at 455 milliseconds. We're pacing here at 410 milliseconds. Probably could have paced a little bit slower than that. Let's figure out, did we advance the tachycardia? Yes. Which is the last advanced QRS? And this is critical because if you didn't make this measurement, you might have thought that this stim captured this QRS. It doesn't. This stim advances that QRS. How do I know? Because this cycle length still is sped up to the pacing rate. Okay? So this is the stim to QRS time, really long. This is actually a pretty easy post-pacing interval to measure. First little sharp electrogram that's captured, not seen during pacing. All right, let's go through our checklist to figure out if this is a good place to ablate. Post-pacing interval is longer than the tachycardia cycle length, right? We're not in the circuit. It's almost game over right there. But you might have, if you didn't make this measurement, have been excited because you see a fractionated electrogram, a really long stim to QRS. Oh, that's terrific. It looks the same morphology as the VT. So you might have gotten very excited about this site if you didn't go through all the steps because of that fractionation and the long stim to QRS and the identical QRS during entrainment as during VT. But the problem is you're not in the circuit, and you know that from that long post-pacing interval, right? The stim to QRS we don't need to know the exact percentage because we're not in the isthmus. So I actually don't care about the percentage because the PPI is longer than the TCL, but it's very long. So how does this add together? What type of site is this? Well, this is that adjacent bystander site, right? This is the place where you get a really long stim to QRS, but it can look exactly the same as the VT because you're attached to the isthmus, but you're not actually in the isthmus. And if you ablate here, you're not going to terminate the VT circuit because you're in a blind dead end, a dead end here. And another interesting clue in this case, where you have this really long stim to QRS, that this is not a good site, is here the electrogram to QRS timing is shorter than the stim to QRS timing. Why is that? Well, think about it. During pacing, the stim to QRS time is going to be this yellow arrow, right? But during VT, when you reach this sort of branch point to continue along the isthmus or backtrack into the blind end here, the adjacent bystander, you actually are activating this limb and this limb at the same time in parallel rather than in series. So by the time you get to this electrogram that you're recording, it's late, and so the electrogram to QRS timing is going to be shorter because these are sort of happening in parallel at the same time than during pacing from that site and exiting out in series, one and then the next. That's an important principle. Electrogram to QRS timing shorter than stim to QRS timing is another clue that you're in a bystander. But the most important one is that your post-pacing interval is long. Another example. Here we have VT at 362 milliseconds. By the way, all of these examples are from my group, my EP group. I'm very proud of them, and I went through a lot of cases, by the way, to find all these examples of different sites within VT circuits. So kudos to my colleagues for doing all these great cases and giving me material for this presentation. We paced here at 340 milliseconds, a little faster than the tachycardia. Let's see, did we accelerate the VT to the pacing cycle length? Yes. And which is the last advanced QRS? It's this one. Okay. What is our post-pacing interval? It's this, right? We can see the far field signal is not captured, and we can use as another clue. You might initially say, oh, well, what? Maybe I measured at this thing. Well, that might be this here. It's actually not captured, but in addition, you can use that trick of the EGM to QRS timing, which is identical to the stim to QRS timing here. So let's go through our checklist once we've determined the correct post-pacing interval, which in this case is basically the same. It's within 5 milliseconds of the tachycardia. The QRS morphology is the same, so we're exiting out the same way during pacing, during entrainment as the VT. And the stim to QRS timing here is 120 milliseconds. And when you compare that to the VT cycle length, that's 33%. So here we are in the central isthmus, a little bit maybe toward the exit, a little bit distal. So this is perfect. I mean, this is the exact place that you want to ablate. It's in the isthmus, sort of central toward the exit. This is a perfect place. And you have this nice mid-diastolic fractionated potential. You have a perfect post-pacing interval. Your QRS is the same, and the timing from stim to QRS is ideal. Fantastic. A great place to ablate this VT. All right, let's get into some interesting different types of examples of different relationships with the circuit. Here we have VT at 360 milliseconds. We're pacing at 340 milliseconds. And let's figure out, did we accelerate? Yes, we did. We advanced the tachycardia, which is the last advanced QRS. It's this one, immediately adjacent to the pacing stimulus. What's our post-pacing interval? It's this. How do I know not to measure to these? Well, I can see those things here, so I'm not going to measure to those things, right? Here's the first sharp electrogram that we captured. Let's go through our checklist here. Our post-pacing interval is, within 30 milliseconds, 13 milliseconds longer than the TCL. We'll say that's in, so we're basically in the circuit. Here, the QRS morphology is different, right? Most notably, well, in lots of the leads, but for example, in the inferior leads, very, very different morphology. What does that mean? Well, we are not inside the scar and exiting in the same way that the VT was exiting. So our relationship to the circuit is not being in the isthmus area, or frankly, even in an adjacent bystander area. The morphology is different. Therefore, somehow we're getting to the bulk of the myocardium in a different way. And the stim to QRS is really short. So how do you combine these things and figure out where we might be? Because we're in the circuit, right? But we're not in the circuit inside a critical isthmus inside the scar. Well, here we are in an outer loop. This is what an outer loop site would look like, right? Because in addition to being in the circuit, and initially you might say, oh, as long as the post-pacing interval's in, that'll work. Not so, because in order to successfully ablate VT, you have to connect two barriers and completely cut off a critical limb of the VT. If you were to ablate on the outside of the scar during where the wavefront kind of escapes out to create the QRS and loops around, all you're doing is you're just kind of pushing out this barrier a little bit. The VT can go just around your lesion, right? And unless you did a whole line of lesions connecting this barrier to something else like the mitral valve or another scar or something like that, you're very unlikely in an outer loop site that's breaking out directly to the myocardium, making a different shaped QRS. You're very unlikely to terminate the VT here. So this is not a good site, even though your post-pacing interval tells you that you're in the circuit. You're not in a critical isthmus part of the circuit. Here's another example. VT, 360 milliseconds. We're pacing at 320 milliseconds. Did we advance the QRSs? Yes, we did. So here is the last advanced QRS. Here is our post-pacing interval. This is very simple, not really too confusing because there's really one main sharp component that we measure to. Let's go through our checklist. So here the post-pacing interval is greater than the tachycardia cycle length. That tells us we're out of the circuit. We're not in the circuit. So right away that tells us this is probably not a good ablation site. But in addition, the QRS morphology is different. You know, in some of the leads it looks a little bit similar, but for example, look at, V4, V3, completely different morphology. So we're not in a critical part of the scar that's exiting out the same way as the VT at all. Morphology is different, and we're not in the circuit. Stim-QRS is short. The percentage doesn't matter because we're not in a critical isthmus area. What is this? What do these characteristics tell us about this site? This is a remote bystander. This is somewhere out in the myocardium. We're not in the circuit. We're away from it. And we're creating a different shaped QRS. So there's no way that ablation here is going to be helpful, right? You're not in the circuit. You're not even in the scar exiting in the same way. This is just a remote site somewhere else. Don't ablate here. What about this example? VT, 435 milliseconds, pacing at a little fast maybe, 390 milliseconds. This is not that hard to figure out which is the last advanced QRS, but we've shown we have accelerated the tachycardia to the pacing rate. Here you have a longer stim-QRS time. The post-pacing interval here, pretty straightforward, is that. Measure to the sharp electrogram that we are capturing. Let's go through our checklist. Well, our post-pacing interval is clearly long, so we're not in the circuit. So again, game over right there. The QRS morphology is different, so also not in the scar exiting the same way the VT does. Interestingly here, the stim-QRS is long. What type of relationship do we have to the circuit here? Well, this is another remote bystander in another area of scar that is not adjacent to, not related to where the VT circuit is. Again, completely ineffective ablation site here. We're not in the circuit, the PPI is long, the QRS looks totally different. I just found this example interesting because you might initially be excited when you pace and you say, oh wow, look at that long stim-QRS. All that tells you is that you're in scar somewhere, right? In this case here, it's just not related in any way anatomically to the VT circuit, so it's not going to work. So simply pacing somewhere and seeing a long stim-QRS doesn't tell you about your relationship to the VT. It just tells you you're somewhere in scar and there's a delay getting out to make the QRS from that site. I'm giving you the answer to this one first. This is an inner loop, because inner loops are complicated because sometimes they participate in VT and sometimes they don't. They're more passive. And I want to show you this example. In this case, actually, it is participating in the VT. How do I know? Here's the VT cycle length, 575 milliseconds. Pacing at 500 milliseconds, a little bit fast. It does the trick here. Did we accelerate the QRSs? Yes, we did. Which is the last advanced QRS? It's that one. So the last stimulus is going to that QRS. Okay. What's our post-pacing interval? It's this. How do I know? Well, it's really the main electrogram. All this fuzz, all this stuff looks like it's replicated here, but we don't see this during pacing, so we must be capturing it. In addition, the stim to QRS and those EGMs to QRS are the same. Another confirmation that maybe that's the right way to measure the post-pacing interval. Let's go through our checklist here with this inner loop site. The post-pacing interval is in the circuit in this case. The QRS morphology is the same as the VT. We have concealed fusion is the term. It's the same. And the stim to QRS is really long in this case, right? 415 milliseconds. And as a percentage Here, that's 72% of the VT cycle length. That puts us not only in the proximal isthmus, but round the corner. You're even further back here, where you're kind of rounding the corner and getting into the central isthmus and then exiting out the same way that the VT does, which is why the morphology looks the same. And in this case, ablation at this site might terminate the VT, but it might not, because you might have here a figure of 8 where there's one internal loop, but there's also this outer loop. So in this case, if this is the faster circuit and you terminated this, you might slow the VT, which might have the same morphology, but exit out this way because you only eliminated one of the two loops and not the common isthmus between the two. So it gets tricky when you get to inner loops, because first of all, it might be, well, I'll review that in the next slide. But if you have this set of criteria with a really long stim-QRS, you're less likely to terminate. Why is that? Because it may be that you're terminating one of two loops, one of two components of the VT circuit, which could be a figure of 8, right? So inner loops can be really complicated. And let me show you that I highly recommend that you go through this really, really great detailed manuscript from Bill Stevenson from 1993, where he spent an enormous amount of time and thought going through very complex circuits and looking at what would happen if you paced from different sites. And look at the complexity of his images, where he has, you know, common isthmuses and bystanders and inner loops and other bystanders and outer loops, and they computer modeled VTs. And one of the things they looked at was the concept of a dominant inner loop, one that was driving the VT, versus a non-dominant or bystander loop. And they adjusted in the computer model the relative conduction velocity around this inner loop versus around the outer loop relative to each other. So here, for example, with the exact same architecture, here if they modeled it as a dominant inner loop, and you're going to pace from site 6, and they didn't do even trains of pacing, but just single beats. They're going to pace from site 6 here with a dominant inner loop. And they showed here that pacing from that site resulted in a post-pacing interval from stim to electrogram in that same site. It was the same as the VT cycle length, so you're in the circuit. So here is the situation where you have this dominant inner loop, right, versus a passive outer loop. That's one scenario with this anatomy. You could also, though, have different conduction velocities and have a non-dominant inner loop here, where it's faster to go this way around the outer component compared to the inner component if they sort of model in slower conduction. And if you pace in that scenario from exactly the same site, this site 6, you could end up with a post-pacing interval that's longer than the tachycardia. Here they made this a little faster at 444 milliseconds, so you're just barely out, but not that out, right? Because you have a figure of 8 with two circuits sort of in parallel with each other. One's a little faster than the other. And so your entrainment, your post-pacing interval, is going to reflect the speed around the loop that you're in, as opposed to the other one that may be slightly faster if you're in a non-dominant loop here. And certainly if you're not in the VT, if your post-pacing interval is longer than the VT cycle length, then you're not going to be successful necessarily at that site. Although, as I said, even in the former scenario, even if you are totally in, you might actually, if you ablated here, terminate this loop but not terminate the other loop. So the VT overall may not terminate. Anyway, this is a really great paper to go through the detailed analysis of dominant versus non-dominant loops in this manuscript, again from Bill Stevenson in 1993 in Circulation. So let's bring it all together and think about what we learned in this presentation. First of all, myocardial scar contains a network of channels that are slowly conducting and often decremental, and these slowly conducting channels can allow reentry VT to occur. These channels are called late potentials during sinus rhythm or pacing, or diastolic potentials during VT. They're often fractionated, multi-component, and low voltage, and occupy a long period of time. Pacing within the scar will create a delayed stim-QRS with a morphology that reflects the exit site or the exit sites, where the wavefront travels out to break out to the normal myocardium. Electrograms that are captured during pacing will disappear into the pacing artifact, and if you pace at a higher output, you may capture more of the electrograms. So it's actually important, by the way, during VT entrainment to pace, ideally, just at threshold, just barely where you capture. Entrainment pacing should be done just barely faster than the VT, ideally, as I said, at the lowest output that captures tissue, because you want to know that the ablation lesion that you place is going to kill off the tissue that you're capturing. If you pace at high output, you may be near a good ablation site and you're capturing it with pacing, but your ablation lesion may not penetrate that far away. So if you want to know, is my ablation lesion going to result in termination of the VT, then pace just barely at capture threshold so that you know that the ablation lesion is going to kill off the very same tissue that you're capturing. The post-pacing interval is measured to the first captured EGM, as we reviewed many times in cartoon form and in real-life examples. If you have with entrainment a post-pacing interval that is equal to the tachycardia cycle length, that means that that site is in the circuit. If you entrain with a paced QRS the same as the VT morphology, that means that you're in a protected site within the scar, a protected channel that exits the same way as the VT. If the stim to QRS time during entrainment shows how far you are from the exit, meaning how far back are you into the scar, into the critical isthmus, and in the central to exit zone, that's the ideal place for ablation, although further closer to the exit or further closer to the entrance can also work. As I said, I just stated this, ideal VT ablation is in the isthmus mid to exit. Entrainment with concealed fusion, meaning the shape looks the same during pacing as during the ongoing VT, and a long stim to QRS may not be a good ablation site, because if you have a long post-pacing interval, that may mean you're in the site of an internal bystander, and everything looks tempting, but if that PPI is long, it will not work. If you have a pace map during sinus rhythm with a long stim to QRS and it matches the VT, that may not be a good ablation site. It just means you're exiting in the same way. Again, you could be in that bystander. That's not a critical part of the VT circuit. But conversely, if you have a pace map with a poor match to the VT, it still could be a good ablation site, because it could generate a VT that's going out the entrance with or without fusion going out the exit as well. And if the shape is different, it still could be in a critical isthmus. So don't be discouraged if you pace from a site with a long stim to QRS and the shape looks different from the VT. That still might be critical to the VT circuit. So you should put them into VT if they can tolerate it and do entrainment. And there has been a great evolution of substrate mapping techniques, including looking at the timing of electrograms during pacing, during sinus rhythm, figuring out the timing of those late potentials, the relationship between one late potential site and another in terms of the isochrones, and trying to figure out if there's decrement, and with the timing, how can we figure out what is the machinery, what are the critical components that are necessary for VT to occur that we can figure out during sinus rhythm, and that way you can do an ablation without having to have the patient need to tolerate being in VT, which sometimes is very difficult, as many of these VTs are fast, the blood pressure may be low, the ejection fraction may be low, it may be challenging to do entrainment in many of these cases. So if we could figure this out during pacing or sinus rhythm, that would be a big step forward, and we're a lot of the way there. There are a lot of studies, as I've shown, and many others that are teaching us how to ablate during sinus rhythm in the substrate that we've detected. I hope that this presentation was helpful. VT entrainment is a complex topic, And I hope that by breaking it down into its components, it'll help you think about entrainment in a new way and help you analyze your VT entrainment when you do your cases so that you can be successful in the ablation of reentrant scar-based VT.